Come on in, guys. Come and take your seats. We're going to get started. How was your smoothie break? Everybody enjoy the smoothie? Yeah, Lizette's giving me a big thumbs up. Big thumbs up for the smoothies. Thank you to Cancer Treatment Centers of America for sponsoring the coffee/smoothie break. All right. How did you guys do on your checklist? Did you thank a planning committee member? Did you get a flu shot? Did you check out the hyperbaric chamber, do your health check? Or are you all just too fixated on getting your smoothie? Is that what it was? It was like all about the smoothie. Okay. All right. So welcome back, guys. We are down to our last speaker. Oh, I can't believe it. What did you guys think of the morning so far? Good? Yeah? Excellent. Well, I'm really looking forward to our next speaker because I think his talk is going to sort of tie it all together and bring it home for us. Ladies and gentlemen, our next speaker is Dr. Wael Barsoum, who is the president of Cleveland Clinic. He's also a member of the Cleveland Clinic Board of Governors and Executive Team. Dr. Barsoum is a proven leader who has directed several initiatives to improve clinical outcomes, patient experience, and hospital operations. He holds a joint appointment in the Department of Biomedical Engineering and is involved in the training of future physicians as a professor of surgery at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. Additionally, Dr. Barsoum has a clinical practice as a staff orthopedic surgeon. He specializes in adult reconstructive surgery, including primary and revision hip and knee replacement, hip and knee reconstruction, and knee arthroscopy. Dr. Barsoum is an avid researcher and innovator who leads a productive research team. He holds the Robert and Suzanne Tomsic Distinguished Chair in Healthcare Innovation. He's the principal investigator for a variety of clinical, basic science, and translational studies and has over 40 granted or pending patents. He has over 100 peer-reviewed publications, several textbook chapters, and is an international speaker on the topics of lower extremity joint replacement and healthcare reform. He's the co-primary investigator on a Third Frontier grant funded by the state of Ohio, for which he has designed patient-specific, customized tools and instrumentation for total hip, shoulder, and spine arthroplasty. He obtained his medical degree from The Ohio State University, followed by orthopedic surgery residency training at the Cleveland Clinic and a fellowship in adult reconstructive surgery at the New England Baptist Hospital. He's also just told me he is also a pilot. He's recently gotten his pilot's license. So, ladies and gentlemen, Dr. Barsoum is going to speak to us today about the chapters of a healthy life. Change your chapter by modifying your behavior. Please join me in welcoming Dr. Wael Barsoum.
Well, my wife and my youngest daughter are out at the pool right now. I wish they could have been here to hear that introduction. Would have been impressed. So thank you very much. It's really a pleasure to be here. I've been to the Cayman Islands now maybe 4 or 5 times, and every time I'm here, I'm astounded by the natural beauty and how wonderful all the people are that I meet. This island has an incredible kindness in the people, and it's really an absolute honor and a pleasure to be here. So thank you very much for welcoming us from the Cleveland Clinic here. It's really an honor to be here. So in the U.S., we always show a disclosure slide. If you have any financial disclosures, I'm not going to be talking about anything today that I'm conflicted with, but nonetheless, we're all in the habit of always showing a disclosure slide, so there's my disclosure slide. So when you think about where we are today in healthcare, we have some very real challenges. And along with challenges, the fun part is the opportunities to solve those challenges. How do we make things better than they are today? So when you look at the U.S. healthcare system, and I would argue that it's really more than the U.S. healthcare system, but most healthcare systems around the world, with some exceptions mostly in Europe, where we remain a disease-focused healthcare system. What does that mean? That means we, generally speaking, we wait for people to get sick and then we treat them. Very different than being a proactive healthcare system, meaning we do everything we can to keep people from getting sick in the first place. They are fundamentally different types of ways of practicing medicine. So in a disease-focused system where you are a reactive system, generally speaking, it's a fee-for-service program where a provider gets paid each time they take care of a patient. So the more healthcare you provide, the more you get paid. This has clearly led to rising costs. And unfortunately, as we've seen costs rise, we've not necessarily seen a significant rise in quality that goes with that. It can be difficult for patients to access care in this kind of a market. And generally speaking, you are usually dealing with an unhealthy population. So what does that lead to across the board? Well, again, if you look at some of these slides, you can see that in the United States, we are at the point right now where we spend about 18% of our gross domestic product on healthcare every year. That is significantly more than every other major country in the world. A lot more than every country in the world. So specifically, if you look at the 11 wealthiest countries in the world, the United States spend $8,713 per individual per year on healthcare costs. The next closest is Switzerland at just over $6,000, and then you drop down to Sweden at just under $5,000, down to Italy at just around $3,000. So one would hope that given how much we're spending on healthcare in the United States, we would have incredible quality outcomes for our patients. The reality of it is, if you're really sick, the United States is a great place to get care. But if you're not really sick, it's an okay place to get care. So again, if you look at these 11 countries, you will see that in terms of overall healthcare ranking, the UK gets the highest ranking for care, and the United States falls last. And mostly that's due to access to healthcare, efficiency of healthcare, and incentivizing wellness. These are real opportunities that we have in the United States. And again, I would argue in most parts of the world, not just in the United States. Central and South America, the Caribbean definitely fall within this same category with us. So this is an important point here. As we talk more and more about value-based medicine, when we talk about quality of care divided by the cost of care, it is important to recognize that higher cost does not necessarily translate into better quality. So what do I mean by that? If I buy 5 more MRIs and put them in my hospital, I've increased the cost of healthcare for every patient that walks through that hospital. But have I necessarily improved the outcomes for any of those patients if I didn't really need those MRIs? I haven't. And in the United States, we have the highest number of MRIs per capita of any country in the world. But again, it has not necessarily led to better outcomes. Now, again, I would make the point, if you're very ill, if you need tertiary and quaternary care, the United States is second to none in dealing with those kinds of issues. But in terms of wellness, we have a long way to go. Access to care out of these 11 countries, the United States ranks last. Efficiency is a very real challenge because we have challenges with our insurance administration. I can tell you at the Cleveland Clinic in Florida, we generally require 3 weeks before we can schedule a surgery for a patient because that's how long it takes for the patient to be approved by the insurer. Even if we absolutely know that they need a procedure, we have to usually wait a minimum of 3 weeks. Now that becomes a real challenge because, again, I'll give you a very real example. When the insurer does give permission to do the surgery, they assign it to a specific day. If for some reason, let's say we end up doing a heart transplant at Cleveland Clinic, Florida, and that case has to be bumped to the next day, we can't do it the next day because the approval is for that day. We have to go through the 3-week process all over again. That's inefficiency. That's a failed way of trying to control healthcare costs. It doesn't work very well. Equity, we rank last. We don't provide the same quality of healthcare across all of our communities and all of our neighborhoods. That is a huge opportunity for us. And healthy lives, we don't do very well when it comes to infant mortality and deaths. In fact, we rank last from those 11 countries, and we're second to last in terms of healthy life expectancy. Why? Because we don't do enough in terms of prevention of disease. We don't do enough to incentivize our patients to take ownership of their own healthcare problems. We don't incentivize our care providers to help force patients to take more ownership of their healthcare problems. And that is what we're going to talk about today. How can we do this better? This was a great study that looked at the causes of premature mortality in the United States. 40% of premature mortality is directly related to behavior. 10% to a lack of medical access, 30% to genetics, 15% to social factors, and 5% to the environment. Now you can see when it comes to things like genetics, that's going to be relatively hard to change. But environment, medical access, and social issues, we can certainly do something about, but behavior is low-hanging fruit. That is something that we can change starting today. When I talk about behavior, I talk about obesity, a sedentary lifestyle, smoking. We're going to talk in more detail about all of these. So if you look at the top causes of death, both in the United States and here in the Cayman Islands, you'll see that they are relatively similar. In the United States, heart disease remains the #1 killer at 23%, but very closely followed by cancer at 22%. And in fact, over the last 20 years, we've seen a decline in the percentage of patients in the United States dying from heart disease. Unfortunately, we've now plateaued. We're kind of stuck at this 23% number, but hopefully we'll find some transformative technologies and transformative treatments that may help to bring that number down. In the Cayman Islands, the #1 cause of death is cancer, followed by cardiovascular disease, and then finally injuries and diabetes. I would make the point, though, that for both countries, we have a huge opportunity in terms of chronic, non-communicable diseases. So what do I mean by that? Chronic, non-communicable diseases, diseases that you have for a lifetime that you can't simply pass on, right? So things like diabetes, not contagious, right? COPD, asthma, bronchitis, emphysema, those types of diseases are things that are epidemic, chronic, non-communicable diseases that we can do something about. If we manage those types of disorders in a proactive way, we can make a big difference. Now let's talk very specifically. As I ask people in the room to take ownership of healthcare issues at the individual level, what do I mean by that? Well, #1, there are certain things that we as healthcare providers, we as payers, we as society can't change, right? We can't change an individual's age. You are what you are. We can't change a gender. We can't change a family history, right? If you have a family history of heart disease, that doesn't change, right? We can't will it away. And we can't change race. And we clearly know that there are certain disorders that are more tightly tied to certain races. That's just, again, it's reality. So we have to recognize that these are things that we can't modify today. So let's concentrate on what we can modify. What are the things that we can modify today that in the end are better for society, are better for the individual, and make a difference, a significant difference in terms of healthcare costs? High blood pressure. Clearly, we've shown over and over again that high blood pressure is something that we can modify. Smoking, the #1 modifiable risk factor when it comes to your health, and we'll talk about this in more detail in a few minutes. Cholesterol. Now, there's a lot of questions around what are the ideal targets from a cholesterol perspective, and again, we'll talk about this in a little more detail in a few minutes. And finally, diabetes. So many people think, well, listen, if I'm diabetic, there's nothing I can do about that. Well, the truth is, there's a lot that you can do about being diabetic. There's a lot that you can do actively about better managing your blood sugars and preventing the high peaks and the low troughs that many diabetics deal with on a daily basis. So there's a lot that you can do. You can own this problem and make a difference. So let's talk again about these in a little more detail. So #1, high blood pressure. So high blood pressure is defined, if you read any medical textbook, as a blood pressure that is above 140 over 90. And generally speaking, a target blood pressure is about 120 over 80. Now today, if you have a history of heart disease or if you have a history of stroke, many cardiologists, many neurologists will ask you to try to lower your target even less than 120 over 80. And then there are some diseases where if you have known atherosclerotic disease in your carotids, where you might want your blood pressure to be a little bit higher than 120 over 80. So again, this is really a very personalized metric that you have to determine with your provider, with your care provider. But nonetheless, as a very general rule of thumb, a blood pressure of 120/80 is a reasonable target. And the reason for that is because we know that poorly managed hypertension leads to coronary artery disease, leads to heart attacks, and it leads to stroke. So this is something that we can actively work on, and it's, again, low-hanging fruit that improves healthcare, decreases complications, and decreases healthcare costs. If you hear nothing else from this presentation, hear this slide. Look at this slide and learn this slide. This is by far the most preventable risk factor that you can deal with, and that is smoking. Smokers are 200% more likely to develop cardiovascular disease. If you are a male that has a lifetime history of smoking, you will statistically live 13 years less than a male that doesn't smoke. If you are a woman, you will live 14 years less. And not only do you live a shorter lifespan, your end of life is a lot more miserable than if somebody lives a healthy lifestyle and then dies. So that's important, right? As we think and talk about end-of-life care, we think and talk about the expense for end of life, and we think and talk about how we want to live our final years. You don't want to necessarily live it connected to an oxygen tank. You don't want to live it ideally connected to a respirator. You want to live healthy, right? So this is an enormous opportunity. Not only does it benefit you, not only does it benefit your children who are sitting in the back seat of the car as you're lighting up a cigarette, it also benefits everybody that sits around you in a restaurant that doesn't want to smell your smoke while you're smoking and they're trying to eat. So it's a good thing to make every effort to stop smoking. So again, the two-word takeaway from this, if you hear nothing else, don't smoke. Was that clear? All right, great. Number 3, cholesterol. So cholesterol is one of these areas today that we're seeing a lot of discussion around, and I think it's pretty exciting discussion, right? So let's think back to what we learned in the 1970s and the 1980s around healthy eating habits, right? In the 70s and 80s, all we heard about was don't eat meat, don't eat fats, eat pasta, eat rice, eat carbs, avoid fats, right? And that led us to this food pyramid that tells you eat X number, X number of servings of bread, X number of servings of rice and pasta, X number of servings of vegetables. And as you got to the very top, you just ate a little bit of protein and fat. That was the idea behind it. Well, I think today we're recognizing more and more that that's probably not the right food pyramid, right? I mean, it's going to take some time, I think, before we have real peer-reviewed, prospective level 1 data that we can all hang our hats on and say we absolutely, positively know the answer today. But I think we would all agree that that probably is not the answer, right? Eating a bunch of sugar and carbs is probably not the right answer. Now, because of that, I believe we're going to see some evolution in the recommendations around what your cholesterol profile should look like. So let's talk very specifically, right? Today, if you go and see your primary care doctor or your cardiologist, the general generic recommendations are total cholesterol below 200, your HDL above 55, your LDL below 140. So there's a whole set of recommendations around this. Now, if you have a cardiac event and you're taking a statin, by definition, the next day they will double your dose of the statin regardless of what these numbers say. So we know that the numbers themselves are not the complete answer. Right? We also know today that eating healthy fats, and we all know about healthy fats that you can get out of fish with the omega-3 oils and healthy fats like olive oil, we also know that those do raise cholesterol levels, right? Because they're fats. But the question is that increase in those cholesterol levels better than a lower cholesterol level that doesn't have healthy fats in it? And this is an area of intense study today. So if you read anything about functional medicine, for example, this is the science of medicine that really talks about what you eat and what you put into your body and then what kind of a role that plays in your overall health, you will realize that it's not the amount of fat, but it's the type of fat that makes the difference. So this is very important and a great opportunity for us to learn more about and to study more about, and I think we're getting there with this. Then comes diabetes, right? So diabetes is an enormous epidemic. It didn't used to be nearly the epidemic that it is today, and I'm going to tell you why in just a few minutes. But this, again, for us is a huge opportunity. So diabetes is defined, and there's some different definitions, but generally speaking, the accepted definition is a fasting glucose level of greater than 125. So what does that mean? It means you don't eat anything overnight, you get your glucose measured the next morning, your glucose is above 125, boom, you're diabetic, okay? But I would probably argue that that's not entirely true, right? Like anything else in healthcare, it's usually not a black and white answer, right? The reality of it is this is a continuum, and now we have terms like metabolic syndrome, where you're almost diabetic, but you're not quite diabetic, right? So the truth is this is a continuum. It's a bell-shaped curve. And in the ideal world, what you want is a blood sugar level that stays relatively stable and does not have high peaks and troughs. And in addition to your blood sugar level being relatively stable, you want your insulin levels to be relatively stable. So a better test than a fasting glucose level is probably a glucose tolerance test, right? Where you don't eat or drink anything overnight, you drink your it's actually disgusting. I tasted it before, this drink that's packed with glucose. And then the doctor measures your glucose level an hour after you drink it and 2 hours after you drink it. But what I would argue is the additional test that goes really well with that is an insulin test. So not only are you measuring your glucose levels, you are measuring your body's response to the glucose in terms of how much insulin it produces. Right? Because we know that if you produce a huge amount of insulin and your blood sugar remains normal but is still relatively high, that your problem isn't that you're not making insulin, it's that you're insulin resistant, which is a completely different treatment, right? The way you treat insulin resistance is predominantly through exercise. It's through weight loss and exercise, and that can make a very big difference. We also know that there are two different types of diabetes, and these two different types of diabetes do have, to some degree, different pathogenesis and different treatments, right? Type 1 diabetes is usually first diagnosed in children and young adults. Type 2 diabetes is something that evolves over time, and is probably a lot more related to lifestyle and genetics, but lifestyle plays a huge role there, than type 1 diabetes. We all know the side effects that come with diabetes: heart disease, blindness, peripheral neuropathy, kidney failure. Ultimately, you can get amputations, require dialysis, kidney transplants. Again, a huge social and economic opportunity and a great wellness opportunity, right? So there are millions of people that live with a diagnosis of diabetes that take care of themselves, actively modify their lifestyles, and live very normal lives. But again, this is an opportunity for us to work together to make this happen. So let's look for a minute at dietary factors that are associated with modifiable risk factors, okay? So we're going to concentrate on two of them because these are two things that people, again, starting today, can take ownership of and do something about it. Number one is sugar consumption, and number two is obesity. And I'm going to show you a few slides at how these two factors have played a very real role in the epidemic that we have right now around certain diseases. So this data comes from the United States, but I would guarantee you that this is applicable across the world. This is a health style decision, a health style change that we have made as a society that is simply not okay. So back in 1700, the average American ate 4 pounds of sugar every year. In 2009, the average American ate 180 pounds of sugar every year, okay? And then not just the glucose, not just the sugar, but we also eat fructose, lactose through the milk we drink, right? There's all kinds of sugars that we take into our body that are different than the white powdery stuff or the stuff that you find in that delicious smoothie that I hope nobody drank outside. I'm teasing. It was nice that the smoothies were there. But it would have been better if it were beef jerky and nuts. So again, this is a very real opportunity that we have to do something actively today, right? To tell our patients, to tell our friends, to tell our family members, cut down on your sugar. I have 3 little girls. I have a 4-year-old, a 10-year-old, and a 13-year-old. And I tell them every day, cut back on your sugar, right? Because I know my father's diabetic. I'm sure that one day if I don't do anything about it, I'll be diabetic, and I don't want them to be diabetic, right? If you are predisposed to having an issue around diabetes or obesity, you have to own that problem and do something about it today. So look at the obesity trend in the United States. In 1962, 48% of Americans were either overweight, obese, or extremely obese. And that little gray line at the very top shows you that really a very small percentage of people were extremely obese, about 1%. If you look today, it's almost 10% of Americans are extremely obese, meaning a BMI over 40. Now, I can tell you, as a hip and knee replacement surgeon, when I have a patient that is obese or extremely obese, I know that they are significantly more likely to have a complication. We know that, right? If you are obese, your risk of an infection goes up anywhere between 2 and 4 times, depending on what your BMI is. If you're getting a knee replacement, the likelihood of iatrogenically cutting your medial collateral ligament more than triples, because it's difficult for the surgeon to see where that ligament is. Right? So these are very real things that we see every day as surgeons, as physicians in a hospital environment, that we know we can make a dent in if we better manage our patients preoperatively. So this increase that we saw, and again, if you look at when this increase happened, between 1980 and 2000, right? What happened between 1980 and 2000? All the talk around cutting out fat, cutting out meats, cutting out proteins, increasing carbs in your daily diet occurred. Eat more rice, eat more pasta, avoid everything else, and look at what happened with our obesity rates. So again, a very real opportunity for us to do something about this today. This is perhaps one of the most depressing slides that I'm going to show you today. So obesity rates in 1994 to 2014. So this is 20 years. So nobody can argue here that there's any genetic change that happened in these 20 years to cause these changes. So in 1994, most of America had an obesity rate being defined as a BMI of greater than 30, less than 14%. Okay, that was the average. In 2000, look at what the map looks like, and in 2014, most of America has an obesity rate about 1/3. So about most of our states, about 1/3 of our patients are now obese. So America, as you likely know, the United States, is the #1 country in the world when it comes to the number of MRIs per capita and the most obese country in the world. #2 is Mexico. All right. The Caribbean islands closely follow suit. Central and South America closely follow suit. So again, this is directly related to our sugar consumption. Now, equally depressing, look at right under that, look at diabetes. In 1994, very small percentage of patients were diabetic. Today, almost every state has at least a 10% risk, 10% prevalence of diabetes. So this isn't magic, right? This is a very easy presentation to give because it's very logical. Eat more sugar, get more fat, get more fat, get more diabetes. Pretty simple to understand. And all of this plays a role when we bring it back to our social responsibility, right, in terms of decreasing healthcare costs. Again, in the United States, I showed you, by 2025, if we do nothing, we will be spending more than 20% of our gross domestic product on healthcare. If we change nothing at all, by 2050, we'll be spending 50% of our gross domestic product on healthcare, right? Like I told you before, I have 3 kids. I want my kids to live in a world where they're not spending half of their money on healthcare, right? It's socially irresponsible to shut your eyes and not do anything about this, right? And part of this is end-of-life care. Why is end-of-life care so expensive when you look around the world? Well, this is an interesting number. So Medicare, which is our single payer for people above the age of 65 in the United States, spends 28% of its budget in the last 6 months of life. 28% of its budget. Now, why is that? Generally speaking, we don't live very healthy lifestyles. So instead of living a really good, high-quality life and then just dying one day, which is, I think, the way that probably all of us in this room would like to die, is one day you just go after living a completely fulfilling life, most Americans live okay, and then they get to their middle ages and they start having more health problems. And then as they get older, the chronic diseases catch up with them and they get pretty sick for the last year or two of life. And that's where the cost of healthcare really starts to balloon. So the whole idea around wellness and better care of yourself is that the life that you live is lived in a healthier state. And that is, I think, again, everybody would agree, would be awesome. It's a better way to live, and it's clearly a better way to die. So we have a real opportunity. So what's, some of the proposed solutions here? The first is to, again, go from being a reactive healthcare system that concentrates on disease to being a proactive healthcare system that concentrates on wellness. And you have lots of stakeholders here that have to be incentivized. Right? This is an awesome quote from Hippocrates. Right? So we all physicians take the Hippocratic Oath in the United States, and so this is not a new idea. So Hippocrates, the function of protecting and developing health must rank even above that of restoring it when it is impaired. Somewhere in the last several thousand years, we lost this message. But that's a message that we need to bring back if we really want to live healthier lives and cut costs in healthcare. So we need to sleep more, we need to be more active, we need to restore our mental well-being. These are the keys to living a healthier life. How can we do that? Well, let's talk a little bit about prevention. Right? 3 different categories of prevention: primary prevention, secondary prevention, and tertiary prevention. So what's primary prevention? Primary prevention is really what we've been talking about all this time. It's cutting back on your sugar, eating a healthier diet, exercising, being active, and trying to do anything you can that's modifiable, decreasing your blood pressure, to live a healthier life. Second is secondary prevention, right? And this is now where we start getting into the other stakeholders, right? Not just the patient, but here now we start thinking about providers and payers, right? What's secondary prevention? Early detection of disease before it manifests clinical symptoms. So if I give you an insurance plan that says that every time you go and see your primary care doc for your annual visit, you're going to have to spend $500 out of pocket, guess what's going to happen? People are going to stop going to see their primary care doctors, right? Dentistry is a great example of this in the United States because very few people have dental insurance. So most people in the United States do not go and see their dentist twice a year. They just wait until they get a cavity, and then they get their cavity filled. Right? It's the same thing here. If you put too much cost into the prevention, these preventatory visits, most people will not take advantage of them. So we need a system that doesn't penalize people for preventative care, right? We want women to go and get breast exams and pap smears. We want people to go and get colonoscopies, guaiac testing, right? We want men to get their PSAs checked and to get their prostates checked. Right? These are things that are important. We have to reduce the difficulty and the out-of-pocket expense associated with these. So again, here you've brought in not just the patient, but the provider and the payer to create a system that incentivizes individuals to have this care. And then finally, tertiary prevention, right? Once you have a disease, how do we prevent that disease from getting worse? And how do we prevent the sequelae of that disease? So if you are diabetic, what can we do to prevent the kidney failure from happening? What can we do to prevent the lower extremity neuropathy that can occur that can lead to amputations, right? That's the idea around tertiary prevention. So again, we can self-manage some of these modifiable risk factors, take steps to stay healthy, manage your blood pressure, your cholesterol, your diabetes. If you are genetically predisposed, and let me really push on this, if you are. Right? We can all say, well, I haven't had my DNA tested, but if your parents were diabetic, you have some likelihood of being genetically predisposed, right? If your parents are obese, you have some likelihood of being genetically predisposed to being obese. So you know what this is. Do something about it. Don't bury your head in the sand. Recognize that that's a risk. So think about that. And if you're diagnosed with a disease, don't ignore it. Monitor it. Treat it. Do something about it. The earlier you do something about it, the better, right? If you're self-examining in the shower and you feel a lump in your breast, don't wait 2 weeks to go see the doctor. Go see the doctor, right? That's a great opportunity to do something quickly. Maintain a healthy weight. Eat a healthy diet. Engage in regular physical activity. Stop smoking. Avoid tobacco. And get your preventative services. And again, it's not just up to us, right? We have to encourage our payers, our government, and our providers to buy into this message. We're starting to do that more and more, I think, not just in the United States, but really around the world. And we have, again, some countries in Europe that I think have led the way to some of this, where they've done a very good job in wellness. But unfortunately, I think as they've done that, we've seen some challenges when it comes to patients that need tertiary and quaternary care. So number one, we need to put more of an emphasis on value and less of an emphasis on quantity when it comes to healthcare visits, right? We need to encourage patients to recognize that healthcare is provided by a team, not just one individual, right? So you may identify with your primary care doctor, but your primary care doctor also depends on their office coordinator. They depend on their nurse, their medical assistant to also make sure that you're getting the best quality care possible. And that's not second-rate care. That's part of the team approach to good health care, right? So that's very important. Again, incentivizing patients to take care of their health status. And patients need to be more accountable for their health to be able to get better outcomes. So let me tell you what the Cleveland Clinic does, right? Because all of this in theory sounds great, but have we done it? Do we walk the walk that I'm telling you about? So this is a sign right outside of our campus. We care about your health, so don't smoke. So at the Cleveland Clinic, not only can you not smoke in the hospital, you can't smoke outside of the hospital, right? I remember when I was in medical school, I'll never forget this sight in medical school. I mean, it's literally horrifying. I saw a patient, a really nice guy, sitting outside in his wheelchair in the winter in Columbus, Ohio, had a tracheostomy tube and held his cigarette up to his tracheostomy in the freezing cold to smoke. Now look, I get it, right? Smoking is a tough habit to break. I understand that, but it's worth breaking, right? That's the key. So we don't allow any smoking on our campus. So you can't go to the fringe of the campus and smoke on the very edge. You just can't smoke at the Cleveland Clinic. We don't hire smokers. Now again, people might say, some people feel that this is pretty draconian, right? Is it reasonable not to hire smokers? Isn't that, isn't that against the law? It's not against the law, right? I mean, we're a healthcare organization, and whether or not you're a healthcare organization, wellness should matter to you and to your company. So we don't hire smokers. Now, what we do is we offer smoking cessation, and we pay for it for anybody that we want to hire that smokes. But if you fail the smoking cessation, you don't get the job. If you pass the smoking cessation, we'll hire you. So we give people the opportunity to improve their lives and to contribute to the Cleveland Clinic if they have been smokers in the past. We offer fitness memberships to every one of our caregivers. So Curve memberships, fitness center, everybody has access to Weight Watchers for free. Everybody has access to yoga classes, again, for free. These are things because we are investing in our caregivers, right? Your caregivers are your very best assets. We're transparent with what we have you put in your body, right? So if you go to one of our cafeterias, you will know how many calories you're taking in. You'll know exactly what you're eating. We've eliminated trans fats from our cafeterias, right? Now, I will tell you, to be completely transparent, we used to have a McDonald's at the Cleveland Clinic, right? We got rid of McDonald's. Finally, it took 10 years to get them out, and some talks about lawsuits and whatnot, but finally they ended up leaving. And that was a big step forward for us, right? I mean, listen, everybody likes McDonald's. I'm not going to tell you that I wouldn't love to have a McDonald's French fry here and there, but we don't eat them. Don't eat them. They're not good for you. We've eliminated all sugary drinks, okay? So you can't get a regular Pepsi at the Cleveland Clinic. You can get a Diet Pepsi, which I'm not necessarily sure is much better, to be honest with you. That's probably going to be the next step, I would imagine. But right now, you can't get a sugary drink. And I will say, I mean, again, in the interest of talking about this, you know, as you're thinking about a healthier lifestyle, and a lot of people do substitute diet drinks for regular drinks, it's not a great substitution because you still get the same insulin surge with the diet drinks that you do with the regular drinks. So the best option is water. Okay? That's the best option. So when we put all of these things into effect, again, you know, I'm telling you that we have an opportunity to decrease healthcare costs. Does it? You know, what have we found at the Cleveland Clinic? Well, number one, we've lost over 500,000 pounds at the Cleveland Clinic, right? So that's pretty cool. We have 52% of our caregivers are enrolled in some type of chronic disease enrollment program. Now, you might ask, what is the incentive for the patients? So simply put, we have a tiered premium program for our healthcare insurance. If you participate in these programs, you get to pay less for your insurance, right? So that's the real incentive that hits your paycheck every 2 weeks. It's a great opportunity. So what are the results of this for the institution? So we pay an average of $391 per month per member for our healthcare insurance. If you look at our employee healthcare costs, this is a pretty cool slide because you're not going to see this in many places in the United States. Between 2004 and 2009, our healthcare costs went up 7.5% per year. 2010 to 2012, they went up 2.8% per year. 2013 was when we started instituting some of these programs with Toby Cosgrove when he became our CEO. 2014 to 2015, we saw our healthcare costs go down by 2.2%. So that's a very real number, right? That is real money that we as a nonprofit healthcare system can reinvest in better care for patients, right? It's an awesome opportunity for us to do that. So this is my summary slide, right? Can you change your chapter by modifying your behavior? I thought that was a great title, by the way, for this meeting. Number one, you can, right? Combat chronic diseases. Set a goal of improving health and longevity. Simply improving longevity isn't enough, right? You need to be healthier as you get older, right? Lower your health insurance premiums and health insurance costs. I firmly believe that this is a real social obligation on our generation's part for our children, and do a better job of being an effective manager of patient populations. So don't be a reactive healthcare system, but be a proactive healthcare system. Thank you very much for your attention.
Thank you very much for that. We do have a bit of, sorry, didn't mean to yell at you. We do have some time for questions. If there are any questions, hold your hand up. We'll bring you a mic.
If I don't know the answer, I'll make one up. So it'll be entertaining.
Yes, I know, well, a comment and a question. Because I quote Hippocrates all the time to my patients, my family and friends, he also said, "Let thy food be thy medicine, and thy medicine thy food." The question is, I noticed when you were talking about diabetes, you didn't mention the hemoglobin A1C, which I think the American Diabetes Association is now using it to diagnose diabetes, so that if you have 6.5% or greater, then you're a diabetic. Yeah. And if you're like between 6 and 6.5, then you're in that pre-diabetic stage where you can actually pick up the insulin resistance. Yeah. And the reason why I prefer this test is because the hemoglobin A1C actually summarizes over a 3-month period what you've been eating. Yeah. Because if you just do the fasting, that is just telling you what your sugar is at the time that you stick your finger or you draw the blood. So what do you think about that?
Yeah, no, I think that's a great point. In fact, again, as I mentioned, I'm an orthopedic surgeon, so we have actually most of our data that looks on risk factors with diabetes uses hemoglobin A1C as the predictor. And you know, one of the challenges that we have, and I'd love to hear your thoughts on this. Are you a primary care doctor? OB/GYN, great. You know, so one of the challenges that we've seen in the orthopedic literature is that patients that have a hemoglobin A1C greater than 8.5, so 2 grams, you know, more than the diagnosis of diabetes, it's very hard to get them below 8.5. 8.5 seems to be the magical number where, and again, I hate to use that because as I think we would all agree, it's a continuum, but where risk factors for diabetic patients start to decrease post-surgically. So I agree with you. Hemoglobin A1C, I think, is a much better test. I also think that a glucose tolerance test with checking of insulin levels is a better test than simply a fasting blood sugar. But I do think we need to get a better sense of how we manage these hemoglobin A1C's level and get them down. And I think part of the reason why it's so hard to get them below 8.5 in the surgical population is because most people try to do it by altering their doses of insulin and not enough try to do it through changing their lifestyle, right? And the key is, again, you're looking at 3 months worth of data. You need to change the lifestyle to make a difference there. So I think it's a great point.
Good question.
I just want to ask if, is it true that a recent study said that if the father is diabetic, it's not, you won't get diabetes as much as if the mother have it?
Yeah, you know, I don't know the answer to that question. I think when we're looking, one of the biggest areas in healthcare research today is genetic testing and what we call precision medicine, right? Looking at the individual and pegging your risk of certain diseases and really using much more individualized care to the patient. I would say with the data that we have today, whether it's the father or the mother, the risk factors are still there. You know, and I don't think that we have enough information to be able to definitively peg the risk being to one or the other. You know, there are some diseases where we know, like mitochondrial diseases, for example, we know for a fact that you inherit all of your mitochondria from your mother. We know that. So we know that if your father has a mitochondrial disease but your mother does not, you're not going to inherit a mitochondrial disease. And we know that the opposite also holds true, that if your mother has it and your father does it, that there is a likelihood that the child will get it. But diabetes, we're not there. We're not there.
Is there any other questions? I have a question. Oh, there's a question here. While we're bringing you the mic, I'm going to ask my question, and we'll get to Ms. Sylvia in a sec. I think one of the things that we can all agree on is we all know what we need to be doing. I don't think anybody, you know, one of our speakers said everybody knows we shouldn't be smoking, and yet people still do it. One of the problems or challenges we have is, you know, information into action, and how do we make people make those decisions and affect that behavior change? In your experience, do you think that incentivizing is the only way to make that happen?
Yeah, I think that's a great question. You know, I think every individual has their drivers, right? So for one person, it might be, I want to live healthier because I want to walk my youngest daughter down the aisle at her wedding. That's a great incentive, right? For somebody else, it might be, what's going to incentivize me is to reduce my premium by, you know, $50 a month. That's going to make a real difference. So it might be money. For somebody else, it might be, I like the team atmosphere of a group medical appointment, a shared medical appointment with 7 other people that are working on reducing, you know, their hemoglobin A1C levels. I think it's fun. It motivates me, and I see it as a kind of as a fun contest. So I think, again, you have to be able to offer all of these different things and understand what's going to motivate the individual to participate and, again, to take ownership. So I think there are a lot of different things that, I mean, what motivated me was my family. My wife telling me one day, you're way too fat, you need to do something about it, right? So I did something about it.
Yeah, I have a comment and then a question. I think after the presentation by Dr. Henry yesterday, I was a bit concerned, but then when when Chandler spoke, Ms. Sophia Chandler spoke, as well as Mr. Rice spoke, I was like, okay, I was kind of leveling off a little bit, because I mentioned to Dr. Henry when I spoke to him after his presentation is that one of the things that we don't take concern of is the same way that they approach drug prevention, is demand and supply, demand reduction, supply reduction. And so I was like, you know what, we're not thinking full circle. So when Ms. Chandler spoke yesterday, I was like, okay, there's some understanding, and that's why I'm saying I'm very grateful that the conference has taken into consideration various aspects, because a lot of people do not realize or take into consideration some of the things that, and I was hoping that Chandler's presentation wouldn't be a lunch presentation, because I think everybody should have really been in the room when that presentation was being done, because a lot of people do not understand that there are some things that happen to people that cause different things to happen to them later on in life, like child trauma. And I have a personal experience where that's concerned, and I'm grateful for the presentation that she made, because it is for the persons like church, my parents, people in the community, that has gotten me to a point of resiliency. And so I'm grateful for her presentation. But my question to you is, based on what you said as relates to prevention, you mentioned incentive, and I'm glad Ms. Ahern's mentioned that just now. I was at the hospital this week, right? And I was in the presence of various people, most of the persons within our local community, and they were very upset. They were talking about our insurance, our medical insurance. And some persons were advocating amongst themselves not to have insurance, because when you pay so much money for insurance, every month you pay so much money, right? And yet for a basic plan, you're only able to go to the doctor once, right? What's the point? I was like, you know what? When you look at, later on when you have a more serious situation to deal with, having medical insurance, it makes sense. But in his mind, he's like, no, I'll just pay out of pocket each time I come, because it doesn't make any sense for me if I have an insurance that is not a benefit to me as it relates to prevention that you mentioned. So how can you suggest, as it relates to our insurance plan, to make that be something that the community at large could, be at a place where I want to go to the doctor, I want to do my checkups, I want to do, so that I can be, I can do better. Because the unfortunate thing is, a lot of persons in our community we know from various research that has been done in Cayman that there's diabetes is a big issue, right? And yet we have a medical system now that does a risk assessment that now puts you at a point where as you're paying a significant amount of money for your insurance. And so that is I'm like, okay, what are you saying to people in the community? We're penalizing you for your for whatever you had before. Yeah. And that's an unfortunate thing that was done recently.
Yeah. Well, that's a great question. I mean, you went right for the jugular with that question. It's a great question. So, what's that?
I can speak to it after
Sorry?
you want to speak.
Yeah, go ahead.
I think, obviously Dr. Barsoum's not familiar with our health insurance law. Well, I don't assume that you are anyway, and the benefits that are under it. But just people don't know or don't seem to be aware, and perhaps we haven't done enough to educate people about that. But when we made changes to the health insurance law in 2013, we significantly increased the benefits under the standard health insurance contract, including a wellness benefit. We introduced a wellness benefit. I think it's $400 a year, in addition to the outpatient benefits that were increased as well. So definitely under the old standard health insurance contract plan of benefits, you're absolutely right. You had $100 a year for your outpatient benefit, and you would use that with one doctor's visit. And that's why in 2013, they made the decision to increase those benefits and to add the wellness benefit. You know, the ministry has been trying to preach the message of prevention, making sure that you're getting your wellness checkups, knowing your numbers, and by making that change and adding that wellness benefit to the basic plan, we thought, you know, we're putting our money where our mouth is, so to speak, to make sure that people can access it. Because you're right, if people know that they should do this, but they don't think that they can afford to do it, and yet they're paying for their insurance, they're not going to do it. The fact is that everybody who has health insurance should, and everybody by law, just I'll plug it now, everybody who's legally resident is required to have at least the standard health insurance contract of insurance. And embedded in that contract, in that plan of benefits, and all the supplemental plans as well, is a wellness benefit that you can use to get your wellness checkups. If you are insured and you're trying to access the benefit and your insurance company is not letting you do that, then you need to contact the Health Insurance Commission and make a complaint. So, yeah.
I think, just to add on to that, I think, that what you're doing here in the Caymans is, that's the evolution that we're seeing in the United States as well. It's, the data that I showed you about the Cleveland Clinic has really been a 10-year effort to decrease our healthcare costs. And the Cleveland Clinic insures about the same numbers, actually more really, than the population of the Caymans. So we have 50,000 caregivers that have insurance through the Cleveland Clinic, and obviously their families. So we have, at any given time, about 200,000 lives in our captive insurance company. And again, I mean, it's taken 10 years to be able to prove that, yes, if you incentivize behavior, it leads to a decrease in healthcare costs. So that's part of the challenge, right, is to get payers to see that that incentive really works, and it does lead to an overall decrease in their expenditures.
We have time for one more question, and we've got...
Yes. Good morning.
Hi, good morning.
Thank you for such a wonderful presentation.
Thank you.
I'm a health educator, and I'd like to ask you, if you know, to explain to the audience about insulin resistance. But having asked you to explain that later on, I just want to add a comment that diabetes is not the end of the world. It is reversible. It is a beginning stage of many other chronic diseases. And so it is an expression that we use, that genetics load the gun, but lifestyle pulls the trigger. So I like your emphasis on doing something now. Do not wait until it's too late.
That's right.
Thank you.
Yeah, I think that's a great point. I think you hit the nail on the head, right? Getting the diagnosis of diabetes is not it's not a terrible thing, as long as you are willing to own it and deal with it, right? And owning it and deal with it is more than taking an insulin shot, right? That's the reality. And the truth is, all of us in the room know people that are diabetic who eat whatever they want and just take a little more insulin, okay? That's not the solution to living with diabetes, right? The solution to living with diabetes is recognizing that your lifestyle makes a big difference. And like you said, the genetics predisposes you, but it's not the writing on the wall. It's how you choose to live. Now, to some degree, obviously, if you're a type 1 diabetic, that may not be quite the case, but most people are type 2 diabetics, right? And in type 2 diabetes especially, you can delay the onset of the increased blood sugar significantly by how you live. You can manage them significantly better without sometimes oral medications, without insulin, by how you live, by how much you exercise. So, so insulin resistance, as you brought up, is kind of it's an interesting issue, because most of us think of diabetes as not having enough insulin, right? Well, insulin resistance is not that you don't have enough insulin. You have plenty of insulin. In fact, insulin levels are sometimes off the charts with how big they are. Insulin resistance means you have the insulin, but your cells don't know what to do with the insulin, right? So they're not pulling the glucose into the cells, and instead the glucose remains in the bloodstream, and that's where you start having the complications. So the key in those cases is to replace the cells, right? Replace fat cells with muscle cells, because muscle cells will manage the insulin a lot better. And that's why exercise is a major help when it comes to insulin resistance. And that's why eating foods that have a low glycemic index, so your blood sugar levels don't go so high, are a big solution to insulin resistance, because it's the high peaks, this is important, right? It's the high peaks and the low troughs from blood sugars that give people most of the trouble. So the key with whether you're insulin resistant, whether you are, it's not a matter of insulin resistance, but a matter of high blood sugars. The key is maintaining a stable, low amount of blood sugar in your system at all times. That's really the key. Does that help answer the question? Okay, great.
And the last question.
Now that finally the World Health Organization has advocated taxation on sugar,
Yes.
and sugar products, and following our healthcare conference of last year with its recommendations, where does the Cayman Islands now stand on taxation of sugary products and reduction of taxation of healthy food substances?
And that's certainly something that I will take back and share with the ministers, and something that, obviously I think as we've learned over the last few days, we need to look at a number of different tools to help us, win the war against the CNCDs and helping everybody to make the positive changes that they need to make. And that could definitely be something that could be on the table.
Can I add one comment to that, though? I think one thing, just a warning. We saw this in the United States with smoking, where the government and local counties and states added major taxes to cigarettes, right? All it did was people still smoked, they just paid more for their smoking. The benefit of the tax was that money was used for educational programs to reduce, teen smoking and people getting into smoking. So I think one thing just to be cognizant of, if the Caymans does take a path around taxing of sugar products, is to recognize that it may not directly reduce your sugar consumption initially. The key is to use that money in education to try to change behavior. That's the key. It's the education, it's not the actual tax, I don't think, that makes the big difference. Exactly. That's exactly right. That's actually a big frustration, right? Is the fact that, it used to be, when I was a resident at the Cleveland Clinic, right, and this was 15 years ago, 16 years ago, if I went to the cafeteria to order lunch, the most expensive thing to order was the healthy food, and the least expensive thing to order was the unhealthy food, right? So that's, to your point, increasing the tax on the unhealthy and reducing the cost of the healthy food is a huge opportunity for us. So.
All right, another round of applause, please. I want to thank you very much for your very interesting and informative presentation and the discussion afterwards. I hope everybody is taking away some idea about how they're going to change their behavior to change their chapter in a positive way. Thank you.
Thank you very much.
And so, ladies and gentlemen, that was our last presenter, but not our last speaker, because we actually were hoping to have the counselor for our ministry, Roy McTaggart, with us today, but he has unfortunately had to send his apologies. I think the problem is that they won't release them from the LA in time for them to get home and, sleep. But so I do have a message that I would like to deliver on behalf of Councillor McTaggart. So good afternoon, everyone. I trust that everyone has had an enjoyable and informative conference as we close out this 7th gathering of the Cayman Islands Healthcare Conference. And what a conference it has been. For starters, we broke our previously set attendance record, and we had more participants than ever. And that doesn't even begin to take into account the people who heard or read about the conference and came and visited us to see our vendors. How about it, guys? Big round of applause for that. I want to thank those vendors and our many sponsors for once again making this important healthcare conference a resounding success. I also appreciate our local and international healthcare providers for giving of their valuable time to not only educate us, but get in the conversation of chapters of a healthy life. I believe that the healthy turnout of attendees is a testament that this annual conference isn't only needed, but it's something that our healthcare providers and residents look forward to each year. We've heard much over the past 3 days about issues related to this year's topic, Chapters of a Healthy Life. We've devoted the past few days examining what I firmly believe is an extremely important topic, looking into the health issues of children, adolescents, women, men, and our elderly. One of the main takeaways from this conference was that if we begin to undertake healthy lifestyles early in our life, we will more than likely continue those habits as we get older, thereby reducing the instances of debilitating diseases that hit many of us in our older years. But frankly, that is not a new concept. The great inventor and businessman, Thomas Edison, once said, and I quote, "The doctor of the future will no longer treat the human frame with drugs, but rather will cure and prevent disease with nutrition." Remember, Mr. Edison lived in the late 19th and early 20th centuries, and it's too bad that we haven't heeded his words. But I'm heartened by learning through the presenters at this conference that there is a paradigm shift in the way most healthcare professionals are addressing the health of their communities, from the cradle to grave, as it were. And we, here in the Cayman Islands, have heard in these past few days how we can prevent and control the non-communicable diseases that are right now the top killers of our people: cancer, cardiovascular disease, and diabetes. These diseases are so preventable with the right balance of a healthy diet and lifestyle that includes physical activity. Yes, as our forefathers and mothers consumed the same bread kind and other carbohydrates that we do today, but the difference is that they didn't spend their days in air-conditioned buildings and ride in air-conditioned cars to get from one point to another. No, they worked the grounds and they went to sea. They fished, they walked, they were active. Today, most of us live very sedentary lifestyles, and it's killing us, quite literally. So I applaud our presenters for giving us food for thought. While all our healthcare conferences give us good, tangible, and useful information, I believe this year's conference has not only made us stop and examine our own lifestyles, but it's given us some tools to reverse some of our most unhealthy habits. The Ministry of Health and our sponsors use these annual conferences to make a real difference in the health and well-being of the people of the Cayman Islands. As you would have heard Friday night, we adopt policies and pass legislation to help ensure the best health care for our people. While it's not government's job to dictate healthy lifestyles to the populace, it is our remit to provide the services, policies, and legislation that help promote health throughout the islands. While this healthcare conference is drawing to a close, it doesn't mean that the Ministry of Health is going to sit back and pat itself on the back for another job well done. Well, we might, for a little while. Instead, we will begin planning immediately the next and the 8th annual Cayman Islands Healthcare Conference. And we will do it with the feedback from the community and from you, our participants. We want these conferences to be meaningful. So instead of coming up with our own agendas, we reach out to you and the wider community to listen to and try to address your needs through these conferences. We've seen through these conferences many people take on board what was learned and adopt healthier lifestyles. And I hope that is a takeaway for you from this year's conference. I again thank our sponsors for making this event a success. We in the ministry can make all the plans that we want with all the public input we can get. But if we don't have the companies to sponsor this event, it just would not be possible. So it's through their sponsorship that we were able to open all of the sessions, panels, discussions, and workshops to the public at large for free. Can we have another big round of applause for our sponsors, please? The main mission of this conference is to reach out to as many of the residents of our islands as possible, offering health and well-being solutions and answers. I thank the public sector, the private sector, and the charitable organizations that have worked together to help us make this conference a reality. It's been a very full, informative, and educational 3 days, and I hope that each of you has enjoyed your time here together. Once again, thank you for helping us make this conference once again such a resounding success. I hope to see each of you here again next year. That's from Councillor Roy McTaggart. And there's not much that I can add to that, really. I hope you all have enjoyed the conference. I have really enjoyed my time here with you. Big thank you to all of our presenters. A huge thank you to the Planning Committee. Ladies, thank you. Well done to the Planning Committee, ladies and gentlemen.
Before we go, please join me in thanking a very, very important person on our Planning Committee, Ms. Jennifer Ahern, and one of the... Thank you. And I'm sure you will agree she's one of the best conference facilitators. Thank you so much, Jennifer.
Thank you very much. And please, also, Lizette is the chair of our Planning Committee, and she's the woman who has pulled us all in one direction to make us get it all together on time. So a big round of applause for Lizette. So a couple of reminders before you go. Don't forget your evaluation, or make sure you fill out the survey when you get it by email. Don't forget to recycle your lanyards so they don't end up in Mount Trashmore. There's a basket on the way out. Thank you all so much. Have a wonderful weekend. And remember the challenge we had from the CMO. Make your own change. Be the champion of your change to make that difference. Take care, and we'll see you next year.